Hi, this is Dr. Ashish Babulkar, shoulder, knee and sports specialist from Pune, and on behalf of Visio and PSRP, we'll take a deep dive on frozen shoulder, my favorite topic. Today, I will dwell upon pure evidence rather than loose anecdotal notes about frozen shoulder. I will also stress upon the features of frozen shoulder such as the diagnosis, the treatment, the myths, the risks, and also at-risk population for frozen shoulder. Also, what is true frozen shoulder? What are the investigations? How does one diagnose? What is the role of injections, physio, exercise, the Visio shoulder app, and the role of vitamins. I will also highlight which cases are amenable for the Visio app and which are the severe cases which need specialized treatment. Let's begin with the controversial part. There are a number of titles for frozen shoulder, including adhesive capsulitis, frozen shoulder, periarthritis. While periarthritis is an illogical term and perhaps adhesive capsulitis makes sense, frozen shoulder is the most acceptable name for this condition. Although informal, it replicates the patterns of disease in a much better form. The second myth that is prevailing amongst physicians is that the condition is self-limiting and will self-heal over 1 to 2 years. There is enough evidence in published literature that this is so not true. There are patients even after 2 years with a weak rotator cuff and restricted terminal range of movement. Linsell's study clearly defined that almost 30% of patients continue to have a disability even 3 years after the onset of frozen shoulder. Joe Dice's study from Leicester, UK suggested that 90% patients took almost 3 years to recover and 10% were still suffering even after 3 years of the disease. Apart from proven research, my biggest grouse is how can you let a patient suffer for 1 year or more and tell him to accept the condition? If this was you and me and we had a limited range of movement in our practice, that would be unacceptable. The third myth is that frozen shoulder follows a freezing path for 3 weeks and then a frozen path for 12 weeks and a thawing part for almost 36 to 52 weeks. Now, each patient is diverse, and why will a shoulder follow a fixed timeline? This is a blatant lie. Some patients may have an easy path and some will have an interminable suffering. One thing is rather clear, diabetic and hypothyroid patients will have a worse outcome than conventional patients. It is no coincidence that diabetic and hypothyroid patients have low immunity and have vitamin deficiencies also. An interesting observation in my practice is that the diabetic and hypothyroid patients may have a recurrence in the opposite shoulder after 5 to 6 years. The path of the disease also tends to be much more severe and grave in diabetic and hypothyroid patients. The patient's main issues are severe excruciating pain, which is worse at night, restricted movements, most typically in the internal and external rotations, and a lack of strength. The onset is usually preceded by subtle neck pain on the same side before the disease actually hits the patient. There is no automatic restoration of strength. In fact, the opposite shoulder may work double and lead itself to another frozen shoulder after 5 years' time. Diabetic and hypothyroid patients have a worse outcome. Typically, patients above the age of 50 and females are more vulnerable. The non-diabetic patients may have an easy path and may recover themselves in 3 to 6 weeks with or without rehab. However, post-COVID, in the last 3 years, I have noticed in my practice that many younger patients in their 30s and males and females in equal measure also have started suffering from frozen shoulder. There's a major dilemma on how to diagnose frozen shoulder. There is no investigation, neither X-ray nor MRI, that can diagnose a frozen shoulder. The diagnosis is largely clinical wherein there is excruciating pain and there is a remarkable restriction of external and internal rotation in these patients. However, one must rule out major other conditions such as neuropathy, arthritis, rotator cuff tear, or calcification of shoulder, which may behave in a similar fashion and will reveal themselves on X-ray or MRIs. Once all major conditions are ruled out and there's a normal X-ray and an MRI, then one can reconcile to the dustbin diagnosis of frozen shoulder. Au contraire, if the external and internal rotations are good, then it is very unlikely that this is frozen shoulder. This may appear strange, but there are major disagreements among shoulder specialists in diagnosing frozen shoulder, and hence the American Shoulder Elbow Society and ISOCOS, a European society, had to come and make a consensus statement on the exact diagnosis of frozen shoulder. When the frozen shoulder is moderate and not severe with a restriction of movements, it can force the patient to go to a specialist and seek treatment. This is mostly in the form of physiotherapy, and there are a basket of options that are there between injections, physiotherapy, even to the extent of arthroscopy. These patients can be subjected to various forms of treatment with diverse results. Steroid injections are the most common first line of treatment. Especially in diabetics, these can raise sugar to alarming proportions and are probably contraindicated. The injections merely reduce the pain but cannot by itself restore the movement or the strength. I am the chairman of the Society Against Steroid Injections and of the firm belief that rehabilitation and physical therapy is the main treatment option for a frozen shoulder patient. Steroid injections can cost 20,000 rupees in Mumbai and about 1,000 rupees in Pune for the same steroid injection. There are other more fancy and expensive injections such as injection hyaluronic acid, which can cost about 5 to 10,000 rupees, and more exotic PRP, which is platelet rich plasma, which can cost 20,000 rupees and upwards. PRP injections are the flavor of the month across the world. I do not use any form of injections because there is not an iota of evidence in any published literature, especially in a randomized double-blind study, to prove that any injection is better than home exercise. Patients are in such grief and are clutching at straws that they'll grab at any magic therapy. It is a fact, supervised rehabilitation is the most enduring, successful and proven treatment program for frozen shoulder. Modalities are a favorite of several physiotherapists such as shortwave diathermy, interferential therapy, ultrasound machines, long wave diathermy. But in my clinic, I do not own a single modality. The modalities can give respite for a brief period of time, probably a couple of hours, and may feel good while using the therapy. But modalities cannot restore function, range of movement, or strength. The relief achieved by modalities can easily be achieved by the patient by using hot soaks and have temporary relief at the same time, or even hot showers. Warm, moist heat, such as a wet, hot napkin, is probably the best way to mitigate pain temporarily. Cold and ice therapy have no role in frozen shoulder. Cold therapy or ice packs are ideally used when there is acute inflammation or a recent trauma. Prolonged excessive use of hot soaks can leave scalds or strange pigmentation on the skin. So patients are warned not to use heat therapy in a prolonged, interminable manner. They should be used for a finite period of time. At the same time, never use heat in the presence of acute injury. Manipulation under general anesthesia is another outdated procedure that is inflicted on innocent patients. There are at least a dozen, if not more, double-blind randomized published studies that have proven that manipulation under anesthesia has no superiority over supervised home exercise programs. This is a crude and prehistoric procedure that should be consigned to antique museums. During a manipulation, the surgeon takes the patient to the operation theatre and under anesthesia attempts to break the scars or adhesions within the shoulder joint by manipulating the shoulder. While this might be successful in a few patients, it can actually inadvertently break several other important structures because it's an uncontrolled maneuver. While some patients may benefit, there are patients who have had disastrous complications after a manipulation under general anesthesia. This includes nerve injuries, ligament injuries, and even dislocations, and the most grievous of all is fracture of the arm bone. I have treated some of these complications, and I must say here that some patients who get complications after a manipulation or anesthesia will never ever get back their normal function. Arthroscopic surgery with a release of the adhesions under arthroscope is a minimally invasive surgery and is a proven technique. But in my practice, it is few and far in between. In my practice, it is the last option after a patient has failed responding to a supervised rehab program. This is rare but not unknown in my practice. The best and pretty much the only way to treat a frozen shoulder is a supervised structured rehab program. In my previous YouTube video for the Visio app, I have dwelled on PSRP, the Pune Shoulder Rehab Program, which is a structured supervised rehab program over the last 23 years that we have used to treat frozen shoulder patients. Here the patients are supervised for the first 2 weeks or maybe 6 days twice a day if they are from out of town, and then they continue to do the same program at home for 6 to 8 weeks. Whichever exercise program you use for treating yourself for a frozen shoulder, it has to have a finite goal and you must determine progression in a finite timeline. In my hands, this is 2 weeks where the patient should feel 30 to 50% better and then qualifies to go on a home program for the next 6 to 8 weeks. In your hands, it might be 3 weeks and 2 months after that. It is pertinent to mention here that patient must experience at least a 50% improvement after the first 2 weeks where the foundation is laid. That progression should be felt in pain, in the range of movement, especially rotations, and also the strength. If after 2 to 3 weeks of supervised physiotherapy, a patient has only minor gains or zero improvement, then they need to change the treatment or take a second opinion. It is pertinent to mention here that you must never use a sling. Although it may curtail the pain, it is actually going to make the stiffness worse. The entire emphasis is on mobilization and restoration of function. Before proceeding to rehab specifics, it is very important to detail here which patient will be amenable to rehab and which will not. We must distinguish here a primary and a secondary frozen shoulder. So what I have detailed with scientific evidence has been primary frozen shoulder. All I have elucidated so far has been about primary frozen shoulder. Secondary frozen shoulder is when the shoulder becomes stiff secondary to some other grievous condition such as cancer, neuropathy, fracture, or post-surgical stiffness. A secondary frozen shoulder may not be amenable to rehab and may not have the same prognosis, and in fact have a much more suboptimal outcome after rehabilitation or any intervention. Pain is the hallmark of frozen shoulder, and this is the most challenging part to treat. So painkillers must be taken as and when necessary, especially to be able to comply with the exercise program. Steroid injections are by far the most effective in reducing the pain. But the first injection works the best. The second and third injection are a waste of time and money. Anesthetists and certain musculoskeletal radiologists offer nerve blocks to patients, which are also effective. But they work on pain and not on strength and range of movement. The benefits from nerve block are only temporary. In fact, in a prospective study that we conducted at Dinanath Mangeshkar Hospital, we noticed that early restoration of rotator cuff strength was the most effective way to reduce the pain and restore function in these frozen shoulder patients. The benefits of supervised rehab are long-lasting and enduring and complete. So frozen shoulder is a vague entity that largely affects diabetic hypothyroid females. Instead of scouting for magic relief, patients should rely on therapists who practice supervised physiotherapy, and especially those who do not use needling modalities or steroids. Self-recovery is unusual and incomplete, and patients should rely on a supervised exercise program, which is ideal. Keep a finite goal of 2 to 3 weeks of supervised exercises followed by a home exercise program. And if you do not perceive any progress in the first 2 to 3 weeks, then perhaps take a second opinion or change the form of treatment. Now coming to the severe form of frozen shoulder, which is grade 3. Here the pain and disability is severe, but more importantly, the external and internal rotation is almost zero. Now to be able to do a supervised exercise program, a patient would need to use bands with an excursion to allow an external rotation strengthening moment. But if these patients have a zero external rotation, then they are not going to be able to do the bands, or the bands may not achieve strengthening because of the restricted movement. So in some of these patients, I may have to bring them into the OPD and in an OPD procedure do an ultrasound guided high volume injection of normal saline, which is water, sterile water, no steroids. Now immediately after this injection is given, there is a restoration of 20 to 30 degrees of external rotation, allowing that patient to be able to comply for that exercise program and the strengthening process. In the rare case, I might have to subject that patient to an arthroscopic surgery or keyhole surgery to release the adhesions and then allow them to resume their exercise program. The final common denominator remains exercise. The Vizio app for shoulder exercises is designed for the mild and moderate form of frozen shoulder. So on downloading the app on an Android or an Apple phone, smartphone, the patient is advised to fill in a questionnaire which ensures that they are eligible to pursue the physiotherapy program on the Vizio app. This would eliminate the severe patients who may not respond to the supervised exercises. If you are unsure, then you can always go on the Vizio app and seek a consultation with one of our empaneled therapists who will take you through a consultation online and ensure that the right person is registered for undergoing the Vizio app supervised exercise. This way, the app ensures that an incorrect therapy is not foisted on an undeserving patient. Either ways, the app gives you a 100% no questions asked return policy, in which case the patient has nothing to lose. In the end, I have to share with you my work on vitamin deficiency and its relationship to frozen shoulder. I have been working on vitamin B12 and vitamin D deficiency in broad shoulder conditions since 2007. I have a few international publications on this subject as a successful culmination of our in-house research programs. There are several myths about vitamin deficiencies, and as a spoiler alert, we will be doing a special YouTube session on vitamin deficiency and musculoskeletal problems. Our work on ferritin deficiency, specifically related to frozen shoulder, is pretty recent and is important to the outcome measures of the treatment program for frozen shoulder patients. There are a lot of myths and misunderstandings about vitamin deficiency on the continuous use of calcium and testing of vitamin levels in these patients. Diabetic and hypothyroid patients have low immunity and vitamin deficiency, and that is why it is pertinent to discuss these issues here. Briefly, let me summarize that frozen shoulder patients should not have vitamin deficiency, and this should be addressed at the same time as rehabilitation is done, and a continuous use of these vitamins will ensure that they do not suffer a recurrence of frozen shoulder in the opposite shoulder after 5 to 6 years. It is important to work closely with your specialist throughout your treatment for your frozen shoulder to ensure the most appropriate treatment plan for your specific condition is done. That way they can monitor your progress and adjust your program accordingly. Without doubt, an early intervention and a consistent exercise program will ensure the early recovery and a complete recovery from frozen shoulder, avoiding you prolonged suffering for a long time. The Vizio app achieves the same in a supervised manner, only virtually. In conclusion, frozen shoulder is an idiopathic disorder, which means we don't know the exact cause and origin of the frozen shoulder. We also know that patients with reduced immunity, such as those with diabetes and hypothyroid, are at risk for frozen shoulder and a more prolonged form of the disease. At least 33% of patients of frozen shoulder are likely to suffer a similar affection of the opposite shoulder after 5 to 6 years, and which might be much more grave and serious than the first affection. Amongst the plethora of treatment options that are available, the most enduring, reliable, and scientific program is a structured, supervised exercise program. There is no logic or science in succumbing to magical treatment options such as modalities, injections, and certainly not manipulation of the shoulder under anesthesia. Whichever exercise program one chooses should yield time-bound results and improvement not just in pain, but also improvement in the range of movement and restoration of strength. In our experience, you will perceive improvements within 2 to 3 weeks of starting the physio program. And if that is so, then please pursue the same exercise program over 10 to 12 weeks in our hands, and perhaps in your hands it might take a couple of weeks extra. The Vizio app is ideal, easy, and super convenient to use at home, as your exercises will be supervised by a virtual physiotherapist and you will achieve the same outcomes progressively. The Vizio app will guide you like a virtual physiotherapist using artificial intelligence and can be downloaded on your smartphone. Since we have paused, I would like you to like, share, and subscribe this. Be